Good evening, everyone. We're going to let a few more people join in as the participants join, and we'll get started in just a moment. So I think we can get started if someone wants to nod ahead for me. All right, great. So welcome everybody to Mind Matters, an amazing collaboration between University of Michigan's Medicine and Department of Psychiatry and JVS plus Kadima. So as we get started, I just want to thank everybody for being here. We have an amazing group of panelists to share with you all. And let me introduce myself. I guess that would be a polite thing to do. My name is Paul Blatt. I'm the president CEO of JVS Kadima. For those who know or don't know, JVS Kadima is an organization that just came together on January 1st, where legacy organizations, JVS Human Services and Kadima, found that we had an amazing way to better serve our community. Our mission is to provide a continuum of supports and services, creating equitable opportunities for members of our community at work, at home, and in their community. We do that by providing far continuum of services in the workforce space, whether that be supporting individuals in your local Michigan Works office, one-on-one career counseling, supported employment, and so much between there, really meeting individuals at their needs. We are so excited to be a part and be able to provide residential supports for individuals with mental health concerns, as well as amazing day programming, including our Zussman Activity Center, Creative Expressions, our Brown Center, and so much more. I'm sure there will be a link on there to get to our website. And fortunately, we are still in that amazing transition space. So you might have to check out both of our websites to really understand who we are. But nonetheless, please know that we are here for the community and the 12,000 members of our community that we serve each year. So in addition to our organization, we are here with University of Michigan Department of Psychiatry, that is part of the Michigan Medicine, a nation's leading health system. The department has a three-tiered mission: advance research into mental illness with the goal of helping those living with mental health conditions to lead a more fulfilling life, educate the next generation of psychiatry health professionals, provide inpatient and outpatient clinical services, consulting, and evidence-based treatment interventions. So with that, I am so honored to, I'm going to get yelled at if I don't do this. For those of you who are on tonight and are looking for continuing ed credits, you will be receiving an email from Core Learning after the event with a quiz and your certificates. And the other thing is, as the evening goes on, please go ahead and put your questions that you have into the Q&A box at the bottom of your screen. You can put it in the chat, but it'll be easier for the panelists to see it on the Q&A, so that would be our preferred method. And with that, let me see, I'm good, wonderful. I haven't messed anything up yet, but I still have an opportunity. So I get to introduce our moderator for this evening, and probably the most exciting moment that I've had since my 12-hour day has been going. I get to introduce Aubrey McFarland. Aubrey is a licensed macro and clinical social worker with a master's degree in social work from U of M. That kind of hurts a little bit every time I keep saying U of M, but I was not going to even mention it tonight and couldn't help myself. In addition to operating and being a former president and CEO of Kennedy Donovan Center in Massachusetts, executive vice president of this organization, and all these other amazing places that Aubrey has had leadership. Aubrey is the executive vice president and chief operating officer at JVS Kadima. And even more important than all of those things, Aubrey is an amazing person that has so much to bring for our community, and I'm proud to call her my friend. And with that, Aubrey McFarland.
Thank you, Paul. You didn't warn me that you might make me cry. I am so honored today to be able to introduce all of our panelists. I am certain that you will get so much great information from them and really enjoy the presentations that we have to put forward. First, I'll introduce Dr. Rich Dopp. He's a medical doctor, a psychiatrist with Michigan Medicine Department of Psychiatry. We also have Michelle Brown. She's a licensed master social worker, also with Michigan Medicine Department of Psychiatry. We have Dana Lassenby, who has her master's in business administration, a master's in arts, and is a limited licensed psychologist. Dana is the executive director and CEO of Oakland Community Health Network. And finally, you'll hear from Dr. Roberto Rinaldi. He is a PhD in limited licensed psychologist, and he is our vice president of clinical integration at JVS plus Kadima. And now I will pass it over to Dr. Dopp.
Hello, thank you very much, Aubrey. Thank you, Paul. It's a pleasure to be here. I think I'll start by just telling you a little bit about the journey that brought me to this event. While my parents grew up in Michigan, when Dad graduated from Michigan State, he took a job with the federal government and moved to Maryland. Mom joined him and studied elementary physical education at the University of Maryland, and then went back to school to become an adaptive physical educator, helping special needs youth incorporate into the PE curriculum. I came to Michigan for undergrad and studied psychology. I like to jokingly call it the study of us humans and our goofy behaviors, why we do the silly stuff we do, but really try to help all of us become our own best psychologist and connect the dots and understand how our feelings and behaviors come together. Spent some time teaching after college, but then came back to medical school with this interest in mental health, and have been working in the Department of Psychiatry for some time. I wear several hats. I'm the medical director at some training clinics on campus, the University Center for the Child and Family and the University Psychological Clinic. I support, our mission in child and adolescent psychiatry, but also we provide same-day consultation service to primary care providers around the state of Michigan through our Michigan Child Collaborative Care, or MC3 program. And that's been a real positive experience because the mental health demands that primary care providers are meeting is really impressive. And it's great to have a chance to support their work. Kind of before I talk too much about diagnosis, I want to acknowledge that we're all unique. We all have our own personalities, some introverted, some extroverted. We all have our own experiences, some positive, some negative. We all have our own biology, our own genetics. But, there is a way to kind of map some of those experiences, some of those symptoms to medical diagnoses. And although it can feel somewhat different than other medical issues, it's actually quite similar to other medical issues. There's a range of blood pressures in the world. And at some point, somebody came up with a cutoff of what is hypertension and what is normal. There are a range of behaviors. And some, when some of what we're experiencing in our feelings or our behaviors start to interfere with how we're functioning, that's when we think of it as crossing over into something that may be a medical issue that should warrant treatment. So our diagnostic and statistical manual, these are criteria based on decades of scientific research of symptoms that cluster together. It's not uncommon to meet criteria for more than one psychiatric disorder. Again, it doesn't fully account for one diagnosis, may not account for the unique experience that someone is having. So 2 or 3 or more diagnoses could be possible. We always want to consider, primary medical issues that may be contributing to symptoms. There's relationship between symptoms of depression and symptoms of thyroid function, for example. There may be other medical issues that are worth exploring and ruling out as well. Next slide, please. Some common psychiatric disorders. There's a variety of anxiety disorders, generalized anxiety disorder, which often also maybe has some anxiety symptoms in multiple arenas, but also sometimes has some physical symptoms of anxiety. Obsessive and compulsive disorder, obsessive thoughts, compulsive behaviors that really can be a pattern that is tough to manage. Post-traumatic stress disorder, social anxiety disorder, separation anxiety disorder. So there's a lot of different types of anxiety out there. There are many ways to meet criteria for depression. There are a number of different symptoms, from sleep difficulties, loss of interest, guilt, low energy, impaired concentration, changes in appetite, how we feel, how we move, our psychomotor function. There's bipolar disorders where people may have, unfortunately, primarily experience of sustained depressive episodes with occasional elevations in mood or energy. There may be thought disorders like schizophrenia or psychotic illness, ADHD, autism spectrum disorder, and more. If I think of, just the effects of a global pandemic, there's some criteria for adjustment disorder that we're all experiencing, right? Adjusting to this new pattern in our living, and then the anxiety of returning back to normal at times. And while I value, identifying a medical diagnosis, I'm often saying to patients and parents that it may be less important what we call it and more important what we do about it. On the flip side of that coin, what we do about it is often informed by the medical diagnosis. So there is value in kind of sifting through some of those diagnostic criteria. Next slide, please. Another thing that I try to keep in mind, as both with respect to diagnosis, but definitely when we think about treatment, is where someone may be headed. I start to think of course of symptoms over time, from early childhood through those really rough middle school years for everybody, to the challenges of being a teen, which are greater now than any time I can think of. The challenges of being a parent of a teen and young kids, which is more challenging than any time I'm aware of. But I also want to think about the biological family history of psychiatric illness as a way of understanding what someone's risk may be over time, both for the current symptoms, but also understanding that in the context of what future diagnoses they may have some risk for. Next slide, please. I think it can be stressful for youth, definitely for parents as well, to have a discussion about a medical diagnosis. Oftentimes, we think of these as, long-standing pieces that people need to work with. And just to point out that, a diagnosis doesn't mean that someone's destined to struggle with these same issues. But I do think it puts someone in a category where they're going to have to figure out how to work with it or how to work at it. And that can be therapy, medicine, self-care, and more. So really think of a diagnosis as more than a label. And again, kind of this idea that it may be more important what you do about it than what you call it, but also kind of what you call it or what you meet, what the diagnostic criteria may fit for that individual can help those guide those treatment recommendations. And so with that brief opening to our discussion this evening, I'm going to turn it over to my colleague, Michelle Brown.
Thanks so much, Rich. Hi, everybody. My name is Michelle Brown, and I'm a social worker at the Outpatient Psych Clinic for Michigan Medicine, where I have been for approaching 21 years as part of my career. So my part of this talk tonight is to kind of give a broad overview of what types of treatment is out there so you can have some information as you're going about making decisions. We know that right now, simply accessing care is particularly difficult. There's been quite a surge in demand since the pandemic hit in particular. And I really kind of empathize with everybody who are struggling to find care right now and probably on wait lists and trying to make that work. In terms of different treatment options available, we've got several different types of interventions that we generally try to coach people on to help improve mood and wellness. The first thing that I usually start with, and most of my colleagues do as well, are some of the lifestyle-based interventions. These are kind of foundational, and I would include things along those lines like establishing good sleep hygiene, for example, working on adequate nutrition throughout the day, regular social interactions with individuals, periods of physical activity. There's research out there that indicates that some sustained physical activity, enough to kind of make you sweat and raise your pulse, maybe 20 to 30 minutes worth, 4 to 5 days a week, has about the same intervention as a low dose antidepressant. And so we would encourage things along those lines in terms of that lifestyle approach. We'd also recommend limiting exposure to other substances like alcohol and other recreational substances, which might affect your mood. In addition to some of those lifestyle techniques, we think about psychotherapy. Psychotherapy is most often provided by a master's level or a doctoral prepared clinician. There's a lot of different ways that you can get your degree and training, but that's the bulk of where psychotherapy is provided. It's far less common for psychiatry to be providing the therapy in today's market, just in terms of supply and demand, as well as cost. In practice, when you're in therapy, what I think most people can expect is that you might be asked to participate once a week on average to get the ball rolling, sessions averaging about 45 minutes in duration, and then working with your clinician to kind of tailor that cadence of sessions to kind of meet your needs. Within therapy, we often think of what are some of the evidence-based interventions. It's how we tend to practice at Michigan Medicine in particular. It's kind of an alphabet soup of therapy with a lot of different acronyms. Some of the most common ones are going to be cognitive behavioral therapy, which works at identifying how your thoughts and your behaviors influence your emotions and where you can leverage change, either with your thoughts or your actions, to help shift your emotions. Other common interventions include dialectical behavioral therapy, which also is very skills focused and tries to address areas of regulating your emotion, tolerating distress, building mindfulness, talking about acceptance of things that can't change, and a willingness to change what could perhaps improve your situation. Other common ones that you might hear of include acceptance and commitment therapy, mindfulness-based cognitive therapy, and then for some of the structured anxiety illnesses like panic, phobia, obsessive compulsive disorder, post-traumatic stress disorder, we often include elements of what we call exposure work. And that's applied a little bit differently for each situation, but tends to have a really effective impact on mitigating those symptoms and improving care. Others that you may have heard about, things that we don't do, but have heard about and definitely feel can be helpful, are eye movement desensitization and reprocessing, and other sensory motor techniques to help incorporate the body along with the thought and the emotion. When individuals are seeking treatment, I also like to think about what are the ranges of intensity. So treatment is generally offered at 3 different levels. The most common is outpatient psychotherapy and medication management that we are just talking about briefly. Also intensive outpatient or partial hospitalization, which tends to run along the lines of a school day, Monday through Friday, typically about 6 hours a day, and inpatient care. Within those levels of care, you can access the psychotherapy, medication management through your psychiatric care provider, which may be a psychiatrist, it may be a psychiatric nurse practitioner, it might be a physician assistant, it might be your primary care physician. All of those individuals can work together for your care. Another area of intervention that we often talk about for more difficult to treat mood disorders is brain stimulation techniques. And I've got those kind of abbreviated, again, a little bit of alphabet soup of electroconvulsive therapy, transcranial magnetic stimulation, and vagal nerve stimulation. All of those are different interventions that you can discuss with your psychiatric care provider to see if they would be recommended for you and what that would look like. Next slide, Kat. Oh, and that's the lifestyle stuff. I guess my slides are out of order with how I was speaking. Apologize for that. Okay. They're all out of order. Okay. So I didn't do the next slide prompts for you, Kat. My apologies. So these are the different interventions that I was speaking about in terms of the alphabet soup for psychotherapy down at the bottom there. You can find more information on all of those therapy modalities and what that might look like through our website, where we have outlined some of the patient care approaches that are commonly in practice. Okay, next slide. Okay, medication management. This is what would be done with your psychiatrist or what we call our advanced practice practitioners. Your doctor will discuss with you, or your APP, the different types of medication and how they might be helpful for your care. Oftentimes, there are common interventions that they may use to treat certain illnesses. But as we know, everybody's biology is a little bit different. And your provider is going to take care to take your medical needs into account, any other underlying illnesses, as well as your family history, which can sometimes be a guide in terms of what might be effective for you. They also might try to take advantage and leverage side effects to make sure that they're helping you get the care that you need. For example, some medications typically affect sleep, and they might alter their prescribing or make recommendations to help take advantage of that if you're having trouble sleeping or if you're struggling with energy. For medication management, visit frequency tends to be less often than psychotherapy. I think it's pretty common to do roughly 3 visits in the first 12 weeks at different cadence levels, depending on your medical underlying conditions and how they're treating you. But we know that we want a quick follow-up after initiation, since that's the time when individuals are most likely to discontinue their medication due to concerns for either side effects or efficacy. After that, your visit frequency will be tailored according to your medical care needs. Visit length with a psychiatrist is typically much shorter than psychotherapy. On average, for return visits, I think most psychiatrists in the community are practicing on roughly a 20-minute model for your return visits. So it does help to be prepared when you go in to help advocate for yourself. Next slide. And these are some of the brain stimulation techniques that I quickly ran through earlier. One that I did not talk about is ketamine, which is not brain stimulation in the same way that ECT, TMS, and VNS would be. But this is a newer intervention, often administered intranasally to help alleviate symptoms of depression and trauma. And this is done under the care of a psychiatric practitioner. I've got our website at the bottom right down below, which offers the expanded information on any of these techniques and interventions that are available. It also has a lot of really helpful self-management tips, things for your lifestyle interventions, stress management, goal setting, mindfulness, and links to other resources. And we would really encourage people to go ahead and check that out for yourself or for a loved one who might be struggling. Next slide. And at this point, I'm going to pass it over to Dana for talking about community services and access.
Thank you. Hi, my name is Dana Lassenby. I am the Executive Director and CEO of Oakland Community Health Network. I'm going to tell you a little bit about how to access services, but also a little bit about the organization and what we do. Our mission really is to inspire hope, empower people, and strengthen communities. So as a community mental health system, we lead a provider service network that assists approximately 27,000 people each year who live in Oakland County. We provide more than 300 service sites across the county. We also manage a large budget, which is funded in part by the Michigan Department of Health and Human Services, grant funds, general funds, and funds supported by Oakland County. We mostly serve people in the public mental health system through our provider network who have intellectual and developmental disabilities, mental health challenges and substance use disorders, as well as a various number of other mental health conditions. The majority of the individuals that we serve are on Medicaid or uninsured. So our goal really is to ensure that individuals are aware of how and to access our services and supports. So we want to make sure that we can improve the quality of life and ensure their engagement and full community participation. So I'm going to talk a little bit about how that happens. Next slide, please. So as I said, okay, there we go. As I said, a community-based local mental health system that we manage specialty services and supports. So again, those include individuals with serious mental illness, children with serious emotional disturbances, intellectual or developmental disabilities. We also care for infant mental health, parents and families, substance use disorders. Most of the people, again, receive our services through the public mental health system, which is managed by OCHN, and they have Medicaid. Next slide, please. As the former speakers have talked and really expanded upon is the need for increased mental health services and supports. I often say that despite all the negativity that the pandemic did bring on, it actually brought attention to the need for mental health services and supports. So if there's anything positive out of it, it did bring attention to, and in some ways, many ways, reduce stigma. So we have strategic priorities that we have developed to ensure that we can provide quality services and supports to our community. And the first of those is to enhance and expand access to non-emergent and crisis services. Non-emergent are services that you could receive within 24 hours or up to 14 days based on the standards we're required to conform to. The other part of that is having crisis services available 24/7. The other priority we have, and it's often talked about, is integrated behavioral health care, integrating physical health with mental health services. But I'll tell you, in our community, often we serve some of the most vulnerable individuals in the community, and they often need more integrated care in terms of looking at their whole life health, looking at food, access to food, healthy food, housing supports, transportation supports, employment and education supports. So when we talk about integrated care, it goes beyond the physical and the mental health needs of the individuals we serve. And we also talk about some of the things that impact our mental health when there's lack of those most precious resources. So the ways that we do that have expanded our ability to serve individuals who have mild to moderate mental health symptoms and to those who have most severe symptoms. And those are through our integrated programs such as behavioral health homes, certified community behavioral health clinics, and complex care coordination for individuals who are really struggling and have multiple experiences in crisis. We also are working on improving our system of care for children and families. I think many of us are aware of the struggles families have with accessing mental health care services for their young people and youth. And so part of our goal is to build an expanded crisis service center for children in Oakland County. And so we hope to have that done in the probably mid-July, but for now we do offer mobile crisis services for children. And I'll explain that in a little bit. We also look at our relationship with our provider network. And so if we assess there's a need or there's a provider that we need to ensure is available for the community, we will seek out providers to make sure that people have access to those services and supports. For example, we also provide and manage a network of ABA or services for individuals on the autism spectrum. And because we realized that some families were waiting much longer than we wanted them to wait to engage in ABA services, we actually added 10 additional providers to our network to ensure those service needs are met. We also have a critical workforce shortage. So what we're doing is looking at our direct service professionals, our direct care workers, and our licensed clinicians, and ensuring that we can recruit and retain those precious staffing to provide those necessary services. Next slide, please. So here's our Access Central Screening Center for Oakland County. It's located in Pontiac, Michigan. You can call our access line on the hours listed during those times if you're not in an emergency situation. We also have a 24/7 crisis line, and I know those numbers will be provided. Next slide, please. So here are some of the crisis services provided in Oakland County. We have OSAS, which is Oakland County or Oakland Assessment and Crisis Intervention Services, which are available 24/7. We have Oakland Crisis Intervention and Recovery Teams that are actually mobile teams that go to the community and respond to a mental health crisis. We have our crisis line, which is 24/7. Our Victims Assistance Program, which is very critical, especially in terms of our response to the recent tragedy in Oxford, Michigan. Crisis Response Unit or Residential Unit is a place where people can go and be diverted from inpatient psychiatric admissions. We have Legal Clinic as well as a Sober Support Unit, which is very unique to Oakland County. This Sober Support Unit allows people who are in need of substance use disorder treatment to come and be assessed and screened until a provider can be identified for them. So we know when people are ready to receive substance use disorder services, you have to be ready to receive them. So this is a way that we can support individuals as they get connected to the appropriate provider safely. Next slide, please. So again, here we go. Okay, my slides were skipping too. Oakland County also has a youth mobile crisis team. So it's available to children, teens, and young adults 0 to 21 when they're experiencing a mental health crisis. This service is provided by one of our vendors, New Oakland Family Centers, and it is a youth mobile crisis service. It is a rapid response by mental health professionals who come on location in Oakland County to wherever the crisis may be. It's on-spot counseling and crisis intervention for young people and their families. They provide assessments and coordinate for stabilization services, as well as ongoing mental health services and supports. So the number and how to reach that team is listed there. Next slide, please. And so we also look at innovative ways and solution-focused ways to respond to the needs of the community. Each year we do an annual needs assessment to determine where are the most needs or where are there gaps in the service array for people in Oakland County. So when we looked at what was going on, especially with young people and youth and their families' attempts to identify and navigate mental health services for students, we found that through the community mental health system, we get calls and we're often able to give them information or referral regardless of their insurance. So as I said earlier, we primarily serve individuals who have Medicaid. This school mental health navigator program, which is supported by Oakland County funds, will actually allow for us to have school mental health navigators. So those mental health services that are not available in the school, the school administrators, teachers, and youth and their families can call a school mental health navigator through our special line, and they will have a connection and they will help them to navigate for additional services and supports that are not available in the school. The other thing that we provide for children, and we're in the process of expanding on, we do respond to crisis services for children at our location in Pontiac. Right now, we have the capacity with 2 beds. Through a grant, we're able to extend that capacity to 10 additional beds. So we're pretty excited about that. So families will not have to go to the ED and wait for services. They can actually go to the crisis stabilization unit, where we can provide children crisis screenings, expedite care coordination, determine the level of care, and provide ongoing engagement and communication with the family. The key pieces of this is really supporting the entire family and really helping families to navigate those services and supports that are needed. So through this assessment center and this crisis stabilization unit, families will have a place to go. And because we know oftentimes if they go to a hospital ED, there is a wait time that is much longer than families really should wait. And often, because of the long wait, people get worse. They come in one way, and it's really not the most appropriate setting to support a family when they're experiencing a crisis, such as a mental health crisis. Next slide, please. So now I'm going to hand it off to Dr. Roberto Rinaldi. Thank you.
Thank you. Hi, good evening. I am Dr. Roberto Rinaldi. I am the Vice President of Clinical Integration at JVS plus Kadima. I'm going to talk a little bit about caregiver support. I'm already looking at the chat and see that a lot of the questions are related to caregiving, or you can tell that the questions are being asked by a caregiver. Caregiving, in fact, is a large population that doesn't necessarily always get as much attention as it really should, right? So slide, please, Kat. So when a friend or a family member develops a mental health condition, we have to understand that it's important to know that you're not alone, right? Often we play a large role in helping, supporting individuals and creating that support system that is so important in recovery and in treatment. Family members and caregivers, so we want to make sure that we define that, and that can be defined as anybody giving emotional, financial, or practical support to a person with a mental health condition. We often find ourselves talking about caregiving as a family member, but that's not always the case. It can be expanded beyond just the family. And in fact, roughly estimate about 8.4 million people in the United States right now are considered to be caregivers of those with a mental health condition. So we're talking about a large number of people here that need just as much as support, maybe slightly different, but just as much as support as individuals that are diagnosed. However, a lot of these caregivers do suffer from what we call caregiver burden, right? Which is essentially the stress that these caregivers feel from taking care of that loved one, that friend with the mental health condition. Slide, Kat. So caregiver burden, we'll talk a little bit about that. Besides being more stress, as some of you that are caregivers can attest to, other things can also lead to caregiver burden. For example, the loved one is financially dependent, right? So that person that is diagnosed, the person that has the mental health condition is financially dependent on that family, on their friends, on their caregiver, which can cause financial stress, not only on the individual, but on the support system itself. Another factor is that a lot of caregivers do not have a plan in place for someone else to take care of their loved ones. The fact is that caregiving for an individual with a mental illness has been shown to take much longer. Caregivers usually tend to be caregivers for much longer than any other illness out there. So caregivers might find it difficult to find others that understand their situation as well. And essentially all these factors are going to add up to caregivers having less time for their needs, less time for their health, and causing caregiver burden. Kat, next slide. So lack of attention, some of the consequences, right? Lack of attention to their own health. So caregiver burden is a lack of attention. About only 1/3 of caregivers report having excellent health or very good health, which is lower than the average to other caregivers for other illnesses. Also, some have reported that caregiving has actually made it worse, made their health worse than what it was before they started doing the caregiving. Another consequence of caregiver burden is that since caregivers put their needs behind their loved ones, they're more likely to have higher levels of depression. It takes a lot of time. It takes a lot of energy to care for an individual with a mental health condition. And that can take a burden on not only the person that is diagnosed, but also the person that is caregiving. And they're also more prone to feeling lonely and isolated, which can cause other conditions like depression, for example. Slide, please, Kat. So much like we talked a little bit about some of the interventions and some of the treatments that are available for those that are diagnosed, some of the treatments that, are very, very similar, and some of the suggestions are very similar of how caregivers should take care of themselves. So stress is probably one of the biggest, right? We need to understand how stress affects us. Stress affects our entire body physically, as well as emotionally and mentally. Some common physical signs are, headaches, low energy, upset stomachs, aches, pains, insomnia. Begin by identifying how stress feels to you. Then identify what events or situations cause you to feel that way. Once you know which situations cause you stress, you'll be prepared, right? Prepared to avoid it and to cope with it when it does happen. Slide. As we talked a little, Michelle talked a little earlier about physical health. So physical health is just as important for caregivers as it is for anybody else. We want to exercise daily. We want to exercise, takes many, many forms, whether it's walking up the stairs instead of using the elevator, running, biking, maybe, a little cardio. But we know daily exercise produces those natural stress relieving hormones in your body and improves your overall health. Eating well is also just as important. We want to maintain a great diet that looks at, whole grains, vegetables, fresh fruits, and that is key to a healthy body. Eating this way can help lower your risk of chronic diseases, which we know is a problem in caregiving, right? We just talked about that, and help establish your energy levels and mood. Get enough sleep. So adults generally need between 7 and 9 hours of sleep to make your nighttime sleep count more. We want to practice that good sleep hygiene. We want to avoid using computers and TVs, that blue light that we're getting from our electronics at night before bed. We also want to avoid alcohol and drugs. They actually don't reduce stress. Most people believe that they do, but they don't. They often, at times, could make it worse. And we want to practice relaxation techniques, deep breathing, meditation, progressive muscle relaxation, or easy, quick ways to reduce stress. This could include things like exercise. So yoga could be a mix of the two, or any other kind of thing like that. Next slide. So we want to recharge yourself. When you're a caregiver of someone with a condition, with a mental health condition, it can be incredibly hard to find time for yourself. And that can cause issues in itself. But learning to make time for yourself without feeling you're neglecting others is important. It's critical for your health as a caregiver. Any amount of time you take for yourself is important. Being out of a caregiver mode for at least, even a little as 5 minutes in the middle of the day that's packed full of obligations can be a meaningful reminder of who you are in a larger scale, in a larger sense. The point is not what you do or how often you do it, but that you do take the time to care for yourself. It's impossible to take good care of anyone else if you're not taking good care of yourself first. Next slide, Kat. And we want to practice good mental habits. So avoiding guilt. Try not to feel bad about experiencing negative emotions. Those are normal. When you allow yourself to notice your feelings without judging them as good or bad, you dial down that stress and you feel more in control. When you feel less stress, you're better able to thoughtfully choose how to act. We also want to notice the positives. When you take the time to notice positive moments in your day, your experience of that day becomes better. Try writing down one thing each day or week that was good, even if the positive thing is tiny. It's real, it counts, and it can start to change your experience of your life and your experience of being a caregiver. And you can start modeling some of those things that Michelle said to those that are receiving the treatment. And then we want to gather strength from others. Support groups exist to ensure that countless of others people have faced similar challenges and understand your concerns. Talking about your experiences can help. In fact, JVS and plus Kadima, we have a support group for caregivers. We've done that over the COVID via Zoom. Before that, it was face to face. And that's done by a licensed social worker at a master's level that does a support group. It's not necessarily therapy, but it is the coming together of individuals that are experiencing the same types of emotions, the same types of things, and being able to sit down and talk about them and work them out together. You may also want to feel like you don't have much time to stay in touch with friends and start new friendships. However, focusing on the long term, you can meet up with a friend once a month. It doesn't have to be for a long time, but you want to continue to have your own support network as well, because we know that the support network is going to be important, not only for the individual with the mental health condition, but also for those individuals that are giving care to that individual. With that, I will finish and we will open the questions and answers. I believe we are suggesting that you put your questions in the Q&A section so that we can read them and properly answer all of the questions. And hopefully we can get to all of them and make sure that everybody gets the information that they need. Thank you.
Thanks so much, Dr. Rinaldi. We've got a number of questions, so thank you to everybody who has put questions in the Q&A. I'm going to start, actually, we'll stay with you, Dr. Rinaldi. Someone has asked, as a caretaker, what do I do if my loved one isn't taking his or her medication and may not have insight into his or her illness?
That's a tough one, right? We have to inform ourselves about what the medication is, how important that is, try to teach that information to the individual. Also, connecting with that physician, connecting with the therapist. There are interventions out there, motivational interviewing, for example. There are ways and interventions out there and modalities out there that can help and increase the possibility for caregivers and physicians. I was a professor at the University of at Oakland University's medical school, and I taught physicians motivational interviewing. How do we motivate our patients in order to do some of the things that we know can help them in their treatment? Caregivers should also learn a lot about that. You can do a quick internet search. There's tons of information on motivational interviewing. However, it's really going to be important to do this as a team, with the intervention team, with the doctor, with the therapist, with the caregivers, all together, and possibly even case managers or supports coordinators getting together to do that.
Great, thank you. And Dana, I'll go to you with the next question. A number of folks have asked, what is the equivalent organization in multiple different counties? So if maybe you could talk a little bit about the Michigan County structure similar to OCHN.
And actually, there are 10 what they call prepaid inpatient health plans. And those programs are the sisters, I guess, of OCHN. And those are the community mental health provider networks for the state. I have put a list of the 10 regions in the chat, and that is to tell you whatever area or county you live in, there is a community mental health in those areas, and that is the public safety net. So if you're looking for one in Detroit, the Detroit Wing Integrated Health Network, Macomb has Macomb Community Mental Health Agency. And so throughout the state, there are 10 PHPs and maybe 46 community mental health specialty providers.
Great, thanks, Dana. And Dr. Dopp, someone has asked, has spoken about the benefit of looking at familial conditions has been mentioned a few times. This person has a daughter who's adopted and wonders if there are any diagnostic tools or genetic testing methods to help identify what might be inherited conditions or those she might encounter in the future.
Yeah, and currently there are not good diagnostic blood tests or imaging studies available to help with diagnoses. It really would be kind of tracking some of those symptoms over time, getting a sense of kind of how that child was functioning through early childhood, elementary school, middle school, and beyond, and really allowing that narrative to guide diagnosis and treatment.
Great, thanks, Dr. Dopp. Michelle, there's a question, is VNS or TMS useful in treating negative symptoms of schizophrenia in a patient that will not take medication?
So I'm going to have Dr. Dopp probably assist me with this because he's going to be a little bit more aware, but my understanding is that all of those interventions are primarily for mood disorders in terms of depression and some evidence for bipolar disorder and some for OCD. And I'll let Dr. Dopp chime in for any additional info.
I had seen that question show up in the chat, so I did a little legwork while others were talking. And so a quick PubMed search came across articles suggesting that vagus nerve stimulation, kind of as Michelle said, has most of its data around affective disorders, around depressive illnesses. But there was a description, a review of available literature suggesting that repetitive transcranial magnetic stimulation can have benefit in relieving positive and negative symptoms of schizophrenia, particularly auditory hallucinations. So perhaps some early evidence for the use of TMS in schizophrenia.
Thank you. And either Michelle or Dr. Dopp, I think this one would be for you too. Someone has a 16-year-old grandson who's struggling. He's on 3 medications for depression, anxiety, and ADHD. Is it typical? And he is in the trial phase trying to figure out which works best. So maybe talking about the length of time until medications start to work and what's a typical treatment model for medications.
Yeah, and this one's kind of in my wheelhouse. Treating depression and anxiety is complicated. They are complicated medical illnesses. And that's why I tend to spread the treatment, as the other presenters have commented, across the role of therapy. Evidence-based psychotherapy is key. There's a role for medicine, and there's also this role for self-care strategies. So hopefully, in addition to the medicine trials, there are those other components being considered. I will say it is not uncommon for people to be on a combination of meds. There's a lot of concern about polypharmacy and being on multiple medications. At the same time, the medicines are somewhat limited in what they'll do. A serotonin reuptake inhibitor can help with some things, but it may not do everything that someone is looking for to treat their depression. It's not uncommon it's actually probably very important to treat the ADHD separately with another medicine. To be on a combination of medicines to treat depression is not uncommon, even in a teenager. And so, I have some personal approaches of start low and go slow and take our time, really getting the teens buy in on all plans, as well as the parent and physician. But I think that this is actually occurring more regularly than people realize. And I think, even individuals who are getting excellent treatment with therapy and medication are continuing to struggle right now, just with all of the pressures that are out there.
Sorry, Dana, there are a couple of questions asking about a point that you referenced regarding difficulty in accessing care because of the challenges of low staffing, et cetera. Can you talk a little bit about the challenges in accessing ER services, psychiatric ER services, and even finding individual psychiatrists?
Huge workforce crisis. I don't think anybody on this panel would disagree with that. There was a workforce crisis prior to the pandemic, and the pandemic just multiplied it over and over again. One is it's tough work. So when we look at our direct care workers, we know that their jobs, they have a heavy job and a heavy lift. And so their rate of pay doesn't always meet or fit the responsibility of doing the work that they do. And so it's interesting because you now have people who will leave direct care work and go and work at Taco Bell or go and work at Target because of the pay and the reduced risk of serving an individual with a serious mental illness or a challenging behaviors. So that's one piece of it. The other piece is there are clinicians now that are able to do telehealth. And so instead of doing the face-to-face therapy, they are opting to stay home with their families and provide care through telehealth. So that's another thing. The other piece of it is financial, of course, in terms of payment, in terms of having just enough people coming into this field and ready to serve some of the most vulnerable people we care for. So what we have done in terms of looking at pay rates and increasing pay rates and finding ways to recruit and retain good people and even try to get people to come back that left during the pandemic, come back and work in mental health. The other piece is really exploring educational opportunities and talking about the career paths and opportunities when you go specifically into mental health. A lot of folks go into healthcare. Less people go to become great psychiatrists like Dr. Dopp. So it's an area that we really do need more healthcare professionals who take an interest in serving individuals with serious mental health conditions. And the number has increased as well. So the workforce shortage is one thing, but the number of people who are now seeking services and support have multiplied. I don't even know how much in terms of, we look at the number of people who are eligible for Medicaid, that number has almost doubled in our community. So people are now taking advantages of the services that are available. And I have a long question, a lot of parts, so I'll try to cover the ED part. The ED part is really much associated with not having those crisis centers across the community as one place that specialize in mental health. And then also when families go to an ED and they get screened and it's determined that they need inpatient or a higher level of care to serve the child, there are a limited number of beds in the community. Or because the child presents with so much challenge, there are hospitals that will not accept the patient because of their ability to care for that child safely along with the other kids that are there for services as well. So it's a very complex problem and it's a workforce issue, and it's just really having the capacity to serve the volume of kids that are now coming our way for services and supports.
Thank you, Dana. Michelle, do you want to add in here as well?
Yeah, just in thinking about the overall demand, one of the things that I've read about and had access to some information is just utilization data from insurance companies' perspective, looking at their utilization change in 2020, 2021. They're reporting on a national level that there has been anywhere, depending on the insurance company, from a 23 to a 27% increase in people accessing mental health services for the first time. So that's a lot of new volume of new business, and trying to meet that need, it's like trying to take a sip of water from a fire hose. And as Dana mentioned, the shortage of beds, if I think about children and adolescents specifically, within the state of Michigan, there's only, I think it's 8, I might be off by 1, it might be 9, psychiatric hospitals in the entire state of Michigan that provide care for children and adolescents. And so that really gives like a disproportionate ratio of available supply to the demand, which is why people are waiting so long in the ERs at this point in time. We are trying to take some steps, and it sounds like each community organization is doing a little bit similar, and we've noticed it also with primary care sites. trying to increase access to services through what's often called behavioral health collaborative care. Rich mentioned the MC3, the Michigan Child Collaborative Care, which is a statewide network that we have been running through Michigan Medicine, where pediatricians can contact and get consultation from a psychiatrist on how to help manage their patient in that primary care setting. Quite often, other primary care sites, whether it's Henry Ford, Integrated Health, Michigan Medicine, St. Joe Health System, they have what's called behavioral health collaborative care, where embedded in your primary care office, there's going to be a clinical social worker who is providing engagement with you as the patient, checking in, doing mental health follow-up with you, and acting as a liaison with your primary care, and also a consulting psychiatrist to, again, try to increase the access to that very limited specialty care in terms of finding child psychiatry in particular is like needle in a haystack these days, but trying to increase that level of access to expertise back in their primary care setting. There are also school-based options that are being offered. It sounds like there's some in Oakland County, and I know that we've got several out here in Washtenaw that we're affiliated with in terms of the Regional Alliance for Healthy Schools, where we've got mental health care professionals embedded in the school system, and also doing training for different school systems through a program to help increase school systems' comfort with providing cognitive behavioral therapy within the school system to make it more accessible for individuals.
Thanks, Michelle. And Dr. Dopp, if you could address children making self-harm statements when they're in school and how advocates can help work with that.
Yeah, and there was one question in the chat talking about someone who was, I guess sometimes I understand it, expressing their frustration or sense of feeling overwhelmed with a statement that sounds really scary and is probably scarier in sounding than it is in reality. It sounds scarier than it really is. So it's not uncommon for schools to want some type of medical professional to weigh in on whether or not this person can return to school. And so I guess the hope is that there might be a medical professional other than the emergency department that could serve that role. Primary care provider. Obviously, sometimes they struggle with that question of knowing. But there's also kind of a history of some youth that's how they express their frustration with a statement like that, and likely doesn't require an emergency psychiatric assessment, perhaps. Yeah, so just hoping to kind of expand some of those resources back to primary care, and that's why we're trying to support those wonderful clinicians around the state.
Great, thank you. Dr. Rinaldi, if you'd like to take this one, how do you support someone who's adult, age of 21, refusing to get the help that they need?
Another difficult one, right? I think again, it's about the entire team. But we have to use that motivational interview. We have to talk. We have to be honest about the situation. But the individual does have a right to refuse. And we also have to remember some of those things. So there's some legalities to it, and it can be difficult to navigate those systems. However, there are resources out there, JVS plus Kadima, OCHN that we just talked about, University of Michigan. There are resources out there that you can connect to, and we can all provide some assistance in supporting that idea.
Thanks, Dr. Rinaldi. Another question, what type of professional deals with an adult with disabilities who is nonverbal dealing with post-trauma? Dana, do you want to take that one?
Sure. I would say, like Dr. Rinaldi talked about, is a team. It requires a team. I know there are multiple providers that provide psychiatry, social work, care coordination, and a number of different things. But when you talk about having trauma-informed care, I would seek an individual who has been trained in ensuring that they can communicate with somebody who doesn't have the verbal skills and provide that level of support. It really is a specialty to make sure that you are trained and you're listening and able to hear the person and look at the way that they're communicating. They are communicating. They may not have the verbal skills, but they're communicating, and having a trauma-informed, trained professional work with that individual would be the first place that I would start.
Great, thank you. Another question here is, how do you support someone with a mental health diagnosis and recognizing that counseling would be helpful, specifically when they think their issues are outside of them and not inside of them? Michelle, do you want to take that one?
Yeah, I think it's a challenge to convince anybody to go to treatment who's not interested. Looking at their reasons for change, what is uncomfortable about their current situation, and whether or not they would be willing to consider is usually where I start. Is for you, this might not feel like a problem. Would you be willing to consider having another person to talk to, so maybe we can problem solve together opportunities to improve the situation, and kind of counter that with where they might be feeling what I call pain points or motivational distress that might help orient them towards change. I think of it like approaching a bullseye target as an archer. You might want them to be in that center target, but I'm just looking to get them on the board and then gradually baby step them over to where they might also want to be. But it has to be with their willingness, and would they be willing to consider reaching out for a different approach, is how I usually try to phrase it.
Great, thank you. Another person has asked, I'm a school counselor. What do you recommend for families to do when they're referred to PES but have a long wait and kids are coming back to school when it's not safe for them to do so? Dr. Rinaldi, you want to take that one?
So I would do the same. I think Dana just presented a great amount of information of where you can call and what you could do in order to receive services. In the meantime, again, looking at that teamwork, having community services and school services together, the more you're going to be able to put together, the better the outcomes are probably going to be. So I think Dana, a little earlier in her PowerPoint, had a bunch of different like hotlines and different programs that OCHN provides for children. And I think referring them to their to some of those programs would be a great in between, and until some of those wait lists kind of go down a bit and we start being able to help individuals a little bit faster. But I think that combination to me sounds like a great idea.
Right, and I like to keep in mind that PES's decision is usually, does this person need to be hospitalized or not? That's their pivot point. And if they need to be hospitalized, they work on placement. And this is going to be the same at any psychiatric hospital or any hospital looking for psychiatric admission. Then you start the waiting game to try to find an appropriate bed, which is a longer delay than any of us would like right now. And if that's not the right level of care, they do discharge them home because there's nothing further that they can offer them at the hospital. Right. That might be an intervention opportunity. I know Dana, I believe, had the slide up, or maybe it was somebody else who had the slide up about New Oakland Family Center as one option, which offers several opportunities through Southeast Michigan for a partial hospital program where it's the Monday through Friday, 6 hours a day thing. They can tailor that down to an intensive outpatient as the individual needs less care. In my experience with New Oakland, they are typically able to get people in relatively quickly, comparatively, within a couple of days, whereas a lot of other places are really struggling. And that can be a nice in-between program between, you don't need to be overnight 24/7, but outpatient just isn't cutting it. That's right, exactly the sweet spot for partial hospital programs.
Thank you. And Dana, if you could answer the question, how do I know the difference between someone with a severe mental illness and a traditional mental illness?
I'm not quite sure of the question. I think that I think what the person's trying to, and I may be wrong, but correct me, but they're trying to figure out, is it a mild to moderate mental health condition up until a severe condition? And I would say something severe is really when the individual is at risk for harm of self or others, and then they don't have the insight to know that they need help. And then some of the milder or moderate conditions, I would say, is just like any one of us could experience. Where you have a situation that's sad, or you have a loss, or you are going through a relationship breakup, or you're struggling with your son or daughter who's having problems in school. So any one of us could have a mild to moderate condition where we have times where we feel sad, or we're alienated, or we don't want to be around people, or we're grumpy. We're just snapping at people and things of that nature because of the situation. But I think when you think about a serious mental illness, and I look to the other experts as well, but when you think about somebody with a serious mental illness, it's pretty chronic. And in many cases, it needs a combination of therapy and medication. Whereas the more mild to moderate conditions could probably be treated with talk therapy and some of the good ideas and suggestions I heard about exercising, getting your rest and sleep. So people who are suffering from a chronic mental health condition, often those things don't turn around with some of the suggestions that we've made. They help, but because they're chronic, they need a more intensive level of care.
Great, thank you. There's another question. Can you talk about training and job placement services that are available? And do you have to be declared disabled to access these? I'm going to ask Paul to answer that question.
Wow, thank you. So I think it's really interesting in our system because our Michigan Works offices are trying hard to figure out how to bring people into services when they self-identify with a disability. So I think the question was services when you don't have a disability. Maybe I'm about to answer that correctly.
Do you have to be declared disabled to access training and job placement services?
So I would say give us a call here at JVS Human Services. Because of the breadth of services that we have, we can connect you with the right person, whether that be connecting you with our business and career services. For folks who don't have an identified disability, we can help you navigate to Michigan Rehab Services if there is an identified disability. But most importantly is just getting connected to somebody to help you with your job search and connect you with training is the most important piece.
Thanks, Paul. Regarding the questions about whether or not you could mandate treatment, we have a request for someone to mention Kevin's Law for any concerns with loved ones who refuse treatment. Who would like to take that one?
I can give a start, and other people I'm sure can chime in. So typically involuntary commitment is pretty tough. We see that a lot through our outpatient clinics sometimes. Usually for hospital-based care is where you start. The unfortunate part about that is that it usually means that the individual has to hit a point of crisis where there's an acute safety need that they have to be held against their will for evaluation. And that's usually a 3-day hold once they're presented at a hospital, or you can complete a petition available through the state of Michigan, and I'll find the link and I'll add it in. As a family member or a concerned friend, if you have a lot of concern, you can create your own, you can fill out your own petition, but then you have to have it taken to probate court to have a judge sign off on it, to then do a pickup order to have the individual brought to treatment, or depending on where you live, your county's mental health might be able to work to come to you to do that type of mental health assessment on the fly. We do that sometimes for wellness checks for people who are presenting with a lot of risk issues, but not able or not willing to come into treatment. Once they're evaluated at the hospital, then that can start the ball rolling for a level of treatment at that end. But the the burden is high to demonstrate that they need that level of treatment without their consent, because we always value the individual's right to choose, and legally the bar is pretty high to demonstrate that they're not in a position to make that choice wisely. Mandating outpatient treatment, what's often called an alternative treatment order, usually comes about after they've had a few hospitalizations, perhaps involuntary based on the hospital. Where I've seen it most successful is when they've had those frequent inpatient admissions, and then the hospital staff provides petition and support for an outpatient alternative treatment order to mandate them to treatment on an outpatient basis.
Great, thank you. And we have one more question. Is autism considered a mental illness? Dr. Dopp, do you want to take that one?
I will say that the Diagnostic and Statistical Manual, the newest one, 5, now describes an autism spectrum disorder, recognizing that there's a variety of ways that someone may present that may have some element of challenges with social communication or restricted interests or things of that nature. So while it is listed as a medical diagnosis, I've also heard it described as a superpower. And so, there's a phrase that we use oftentimes in mental health, is that if you've met a person with autism, you've met one person with autism. They're all very unique and they all are very different, and really present it in different ways, interestingly, which is the idea of this spectrum or umbrella that captures, hopefully, more individuals and giving them more opportunities to connect to care. So that's a long-winded answer to say yes.
Very good answer. Well, I want to take a few minutes and thank Dr. Rinaldi, Dr. Dopp, Michelle, and Dana for all of your insight, your expertise, your willingness to just share so much of your knowledge with the community that's been here on the webinar with us. Of course, we appreciate the Michigan Medicine Department of Psychiatry, Oakland Community Health Network, and JVS for Kadima for sharing you with us tonight. Just to let everybody know, we will share the recording of this video in a follow-up email to all of the participants. And I do want to recognize the Tyler Howard Memorial Fund, which is the fund that supported this event in happening. So again, I thank you. I ask you to please take a look at the resources that have been put in the chat in case you want to take any of those with you. I appreciate everybody's time, and we hope to see everybody again on another webinar soon.